Yeah, thank you for attending this webinar. I know everybody is very busy with your schedules at the moment, and in these times of increasing stress and uncertainty, I think a lot of people are feeling extra heartbeats or palpitations. And I commonly see people who come to see me because they're worried about the heart. They can feel the heart racing or beating more quickly. And many times it may be that they're just under stress, or there are other non-cardiac reasons for their symptoms. But there are a minority of patients who may have a serious underlying heart problem that needs further investigation and treatment. So the main reason for this talk is to help identify which palpitations are benign and not dangerous, and when people may have more serious underlying heart problems and need further medical checkup for their palpitations. So let me first ask you, what do you think about when you hear the term palpitations? Do you think about the times when you drink a bit too much caffeine and you feel the heart racing afterwards, or perhaps you've drunk a bit too much alcohol the night before and you feel the heart go very fast the next morning, or even during the evening when you're taking more alcohol? Or times when you're very stressed, when you're driving and it's very hectic on the streets and you feel the heart racing? Or maybe more appropriate in the current situation, if you're homeschooling and looking after the kids and trying to task doing your daytime job as well as looking after everyone else at home. In these situations, there may be an obvious non-cardiac reason for the palpitations, but sometimes there may still be an underlying heart problems, and these triggers may just unmask the more underlying serious problem that needs further treatments. So the main objectives of this talk are to elucidate what are palpitations and heart rhythm problems, to clarify when they are dangerous and need further assessments, to talk about what tests we may commonly do to try to decide whether or not there is a real problem that needs treatment, how we can manage cardiac arrhythmias if they are found to have any. And I'll give some examples in this section as well, because I think it's easier to understand the treatments available and how we treat certain arrhythmias when you actually see real patients and how they have been managed. And of course, we haven't got any patient data there apart from the examples of how we've treated them. And lastly, I'll end by giving you some advice on how you can lead a healthy life to try to avoid getting any heart rhythm problems. So the definition of palpitations are when one is more aware of the heartbeat than usual. It's usually an unpleasant or unusual awareness of your own heartbeat. Some people describe the heart beating too quickly or too slowly, or some people feel irregular heartbeats or more forceful or stronger heartbeats than usual. And they can be associated with chest discomfort or breathlessness or lightheadedness. Cardiac arrhythmias are actually, by definition, an abnormal heart rhythm. They may be related to palpitations, although you can actually have a cardiac arrhythmia and not feel palpitations. And there are different types of cardiac arrhythmias depending on which part of the heart is affected. Some are benign, others can be more dangerous and need a more urgent treatment. And of course, the two terms are interrelated. Palpitations can be related to arrhythmias, although palpitations may not necessarily be related to an underlying heart rhythm problem. The important thing to ascertain is whether or not there's anything that requires medical treatment. Is there a real cardiac problem or issue that requires further evaluation? And important pointers as to whether there is an underlying problem include whether the heart suddenly races or suddenly shoots up very quickly when you're relaxed and resting, or if the palpitations last for a longer period of time, if they increase in frequency, or they start to cause other problems like breathlessness or chest discomfort or dizziness, then the palpitations are more likely to be due to an underlying heart rhythm problem. I'll cover more of these later in the talk. So what are the risk factors and the causes for palpitations? Of course, heart diseases are common, and we don't want to miss these as an underlying reason, and this is what I'll cover in most of the talk. But there are other non-cardiac reasons for palpitations. If you're not drinking enough water or fluid, you can get dehydrated and feel the heart beat more quickly. If you're stressed or anxious or excessively tired, you can also feel palpitations. Some people feel palpitations after a large, heavy meals. There are some connections, some nerve connections between the gastric system and the heart, and people feel palpitations after meals. If you're anemic, you're more likely to feel palpitations. Some people get orthostatic hypertension. So some people have a low blood pressure or change in blood pressure when they change position, and that can trigger transient palpitations. Some people have poor circulation. And of course, other factors like caffeine, nicotine, and tobacco can cause palpitations. And also exercising. Of course, we all know that the heart rate goes faster when you exercise, but for some people who don't exercise regularly, if they start to suddenly exercise more than usual, they may feel the heart beat excessively fast and feel uncomfortable. And that may just be a factor that they're not very fit and they need to gradually train up their cardiovascular system. This slide shows a little information about the normal electrical conduction of the heart, which some of you may be familiar with. The normal heartbeat starts on the top right of the heart in an area called the sinus node, and the electricity travels down the middle of the heart to the center in this area called the AV node, and then from there it branches down to the main pumping chambers of the heart called the ventricles, and allows the heart to beat in a nice regular pattern, as you can see in this bottom trace. And the normal heart rate is usually between 60 and 100 beats a minute. So technically, if the heart rate is greater than 100 beats a minute, we call it tachycardia. If it's below 60 beats a minute, we call it bradycardia. But some people have normal heart rates, but they can have an irregular heart rhythm, or they can feel skipped beats. Examples of abnormal heart rhythms are some people get abnormal rhythms coming from the top part of the heart called the atria. They may be extra heartbeats, such as shown here, atrial ectopics. They can occur anywhere in the top chambers of the heart. Some people have extra electrical connections in the heart. You may have heard the terms AVNRT or WPW. They're quite technical, but some patients have been told they have these conditions. They just mean there's an extra electrical connection somewhere in the heart. And some people get electrical circuits that form in the heart. Here we see a circuit called atrial flutter, which is a large circuit going around and around the right atrium. Some people have something called atrial fibrillation, which I'll discuss a little further in the talk later. The rhythms that occur in the bottom chambers of the heart are called ventricular arrhythmias. So they can be extra heartbeats from the bottom chambers called ventricular ectopics. But some people get ventricular rhythms that form a circuit in the lower part of the heart. And the most dangerous rhythm is something called ventricular fibrillation, which will cause the heart to suddenly stop beating and cause a cardiac arrest. But these clearly, patients who have this condition would be very, very sick and needed emergency treatments. So a little more about atrial fibrillation. But I'll spend a few minutes to talk about this because it's a very important rhythm. It affects a large proportion of the population, and it's important because it can increase the risk of stroke and morbidity. And it's important not to miss it because there are treatments available for atrial fibrillation. So atrial fibrillation is due to fast abnormal rhythms in the top chambers of the heart. And you can see that the heart rhythm is usually felt as being fast and irregular. And patients sometimes feel palpitations because of the conditions or dizziness or lightheadedness. And as I mentioned, atrial fibrillation is very common. Up to 6% of the population over the age of 65 have atrial fibrillation. And more than 10% over the age of 80 have atrial fibrillation. So it's estimated that about 1 to 2% of the whole population have atrial fibrillation. So if we take Singapore, there's probably about 50,000 people in Singapore who have atrial fibrillation. And the worrying thing is that many patients may not even feel it. So they may not realize they have atrial fibrillation, but nonetheless, there may be an increased risk of having blood clots and stroke. And this slide shows that as we get older, the incidence of atrial fibrillation increases. And at all ages, men are at higher risk of developing atrial fibrillation compared with women. So what are the risk factors for atrial fibrillation? Well, there are a number of important risk factors related to lifestyle. So excessive alcohol intake can increase or trigger AF episodes. If you have thyroid problems, that can cause AF problems. As you get older, as I mentioned, you're more likely to develop atrial fibrillation, and if you're male. But if you have other inflammatory conditions, so that includes an acute infection, or some people get other inflammatory conditions such as arthritis, that can increase the risk of development AF. Sleep apnea is a very important condition. Many of you have probably heard about it, where you have abnormal sleeping patterns and excessive snoring at night. That actually puts pressure on the heart and on the lungs, and that can increase the risk of developing AF. If there's someone in your family with a history of AF, you're more likely to develop it. And if you have any type of heart disease, including previous heart attack or a heart failure or high blood pressure, all of those can increase the risk of getting AF. So when are palpitations dangerous? So when should you start to think about seeking medical attention? Well, really that question depends on what type of rhythm problem you have. As I mentioned at the beginning, there are different types of palpitations. Some are benign, so even if you have a heart rhythm problem, it may not be dangerous and may not need any specific treatments. On the other hand, the more dangerous ones are those in patients who have a history of heart disease, particularly if you have a previous heart attack or coronary artery disease or heart failure, or if you've had previous heart scans, like an ultrasound scan of the heart, which shows that your heart muscle or the valve structure is abnormal, or if your heart, conversely, if your heart function is normal on the scans, then it's less likely that your palpitations are dangerous. But particularly if you have atrial fibrillation or any ventricular arrhythmias, particularly ventricular tachycardia causing blackout or loss of consciousness, they can be dangerous. And some older patients have something called heart block, where the heartbeat is actually too slow, and that can also be dangerous because that can cause people to black out or lose consciousness suddenly. AF, as I mentioned, has increased associated with risk of stroke, which is why it's a particularly dangerous condition. And 15% of all strokes are due to AF. Here we see an ultrasound scan of someone's heart who has a clear blood clot inside the heart, shown in this arrow. And if the blood clot is dislodged and goes into the brain from the heart, it can result in a stroke. And the other important things to recognize are that the stroke related to patients with atrial fibrillation is often worse and causes more disability compared to other types of stroke, which is why it's very important to detect AF at the early stage to prevent a stroke. This diagram gives you a bit more information to show how a blood clot in the heart can break off, can travel up the blood vessels to the brain, block the blood vessel in the brain, and lead to a blockage and a stroke. So this is clearly an important condition that can be treated by thinning the blood to prevent blood clots. So in the next half, I'll talk a little about some of the tests that we can use in patients who have palpitations to decide whether or not any treatments are necessary. The ECG is very commonly done. I'm sure many of you have had ECG done as part of a health screening or a general medical checkup. The ECG is generally a useful test in that it provides some general information on the electrical activity of the heart at that moment in time whilst the ECG is being done. It also gives some other information on the heart, such as whether or not one may have had a previous heart attack. But there are limitations. It's simple and easy to do, but it doesn't necessarily pick up a heart rhythm problem because the patients may have no symptoms at the time of the ECG, but may have intermittent palpitations which weren't manifested during the ECG. Slightly more useful is something called a 24-hour or 48-hour Holter monitor. So in these tests, we connect a number of electrodes on the chest wall of a patient connected to a device, and this monitors the heart rhythm continuously for 24 or 48 hours. Gives us a bit more information, but again, it's not 100% accurate because patients may not have any palpitations during the monitoring period. But also increasingly patients find that it's not very comfortable to wear such a device underneath their clothes when it's hot and sweaty in Singapore for that period of time. And patients cannot shower or bathe during the monitoring period. So that's one of the disadvantages of the test. More useful is a more up-to-date Holter monitor that we use at the Harley Street Heart and Vascular Center. This is something called a patch Holter, which basically has all the information of a normal traditional Holter monitor, but it allows us to stick this monitor onto the chest wall of the patient. So it's a lot easier and more comfortable to wear. And the patient can then do their normal activity, including doing exercises. They can shower with the device on, and it allows them to wear the monitor for a bit longer, up to a week at a time, because it's easier to wear and they can still shower. Increasingly, patients are coming to see me because they're using one of the newer smart watches that can monitor the rhythm or heart rate, and they find that the watch has shown some abnormal rhythm or fast heart rhythm. And I think we're going to see an increase in these patients over time as these devices become more popular. There are some uses with these devices in that they do pick up heart rhythm problems, and there's an important body of literature that shows that they are medically useful. The Apple Heart study recently published validated the use of the Apple Watch to pick up atrial fibrillation. However, sometimes they're not accurate because they may not pick up the rhythm correctly, and it may cause unnecessary anxiety among some individuals. So I would use these devices with caution, but still one needs to have a proper medical assessment if one is concerned about a heart rhythm problem. This is a sort of screenshot you might see if you have a special heart rate monitor. You might see some rhythms that look quite reasonable with a reasonable profile, but other times you may not get very good data depending on the contact and whether there's any artifact during the watch monitor. In terms of what other tests we do in clinic to try to pick up arrhythmias, we sometimes use something called a cardiac event recorder. So in patients who have symptoms infrequently, perhaps once a month or once every 2 months, it's clearly not practical to wear a heart monitor continuously for 24 or 48 hours, which may not pick up the problem. So in these cases, we sometimes let patients loan a heart monitor that they can use for up to 3 months. This is one example of a device called a Kardia device, where the patients will carry that with them in their pocket or in their bag. And when they feel the palpitations, they then activate the device by pressing with their fingers or thumbs. And that device will then monitor the rhythm through the electricity that flows between the two fingers or thumbs. So this is useful, and it has a very high pickup rate in patients who have intermittent palpitations. But clearly, it requires the patient to be able to use the device and to detect the arrhythmia when they feel symptoms. This is another example of a cardiac event recorder called an Omron device, where patients can actually push it onto their chest wall when they have palpitations. Both are equally useful and have been medically validated to be able to pick up arrhythmias. The echocardiogram that you may have heard about is an ultrasound scan of the heart, very useful again in patients with palpitations because it gives us information on the heart structure, the size, and whether there's any valve problems. It's a safe and non-invasive test, so it's useful to do. It takes about half an hour to do in our patients. Some people may have undergone the treadmill test. Treadmill test is often used to check for coronary artery disease as a screening test. It's not 100% accurate, but it's useful as a screening test. I often use it in patients with palpitations, especially if they have palpitations during exercise, because sometimes we can pick up arrhythmias on the treadmill test during exercise, and that gives us the diagnosis. So how do we manage patients who are confirmed to have palpitations and arrhythmias? Clearly, this depends on the type of arrhythmia that you've been confirmed to have. The first thing to do is, I would say that it's very important for your doctor to really try to confirm what the rhythm problem is, rather than just treat blindly and give the patient medication, because some patients may not need any treatment at all, others may need specific medication. So the doctor should really, if you're concerned and have ongoing symptoms, your doctor should assess you carefully, look at your risk profile. So older patients or those with risk factors for heart disease are at higher risk of serious arrhythmias, and perform appropriate investigations. If after having done the test, the doctor concludes that there is no arrhythmia, in other words, your palpitations are just because you're more aware of the heartbeat, but there's no underlying serious heart problem, then there may just be simple advice that's necessary, such as reducing stress or reducing your caffeine intake or alcohol intake or losing weight. And that sometimes is all that's necessary. If, however, you are confirmed to have an arrhythmia, then the question is what type of arrhythmia and what treatment is required. There are a number of heart medicines available. This is a list of some of them. There are also more specific arrhythmia medications that we sometimes give depending on the arrhythmia. Some patients with certain types of palpitations may be suitable for something called an EP study or electrophysiological study and catheter ablation. So this is a minimal invasive keyhole procedure that we can use by introducing catheters from the blood vessels in the legs up into the heart. And it can actually be curative for certain types of arrhythmia. So it can be a very good treatment, particularly in younger patients or patients who don't want to take long-term medication. There's usually a very high success rate for this arrhythmia as long as for this procedure, as long as it's done for the right arrhythmia. And the main advantage is that it can be curative and avoid the need for long-term medication. So the procedure involves passing some electrodes, thin electrical wires from the blood vessel in the leg, vein or artery up to the heart. And then depending on where the problem is, once we've identified the abnormal rhythm, we can then deliver some energy, either heat up the tissue of the heart to destroy that area of the heart that's causing the palpitations, or sometimes we freeze part of the heart muscle that disrupts the electrical circuits, as shown here, that causes the palpitations. But as I say, this needs to be carefully done and assessed before a patient is deemed suitable for such procedures. The other important treatment option to remember is in patients with atrial fibrillation, one of the important roles of the doctor is to decide whether or not the patient has a higher risk of blood clots and stroke. And if they are deemed to be at higher risk based on certain criteria, we would recommend the patient to be on long-term blood thinning medication. You've probably heard about some of these medications, such as aspirin or warfarin. Aspirin is commonly used for patients with coronary artery disease, but is actually not recommended for patients with atrial fibrillation to lower the risk of blood clots because it's not effective. So warfarin is not suitable just to lower the risk of stroke in patients with AF. Warfarin is still useful and can be used, although those of you who have heard about it probably realize it's not easy to take. There are lots of interactions with warfarin, and patients need regular blood tests. Increasingly, we're using these modern and more convenient blood thinning medicines, the newer generation of blood thinning medicine in patients with atrial fibrillation to lower the risk of stroke. And for a small subset of patients with atrial fibrillation who cannot take blood thinning medication, there are other treatment options, such as a left atrial appendage occlusion device, whereby we can actually put little devices inside that part of the heart that can cause blood clots to lower the risk of blood clots without the patient needing long-term medication. So in the last few minutes, I'd like to give you some examples of patients I've looked after who have had arrhythmias. I've tried to pick a selection of cases that sort of show the whole spectrum of people that may develop heart rhythm problems. And some of you may be able to identify with certain types of these patients. And if you feel that some of these situations may be applicable to you, I would suggest that you have further medical checkup. These are real patients, but the pictures are not the actual patients. They just give you an idea of the sort of profile of the patient that I'm referring to. So the first case was a lady I saw several years ago who was a 68-year-old lady. She came to see me for a general heart checkup. She had a history of high blood pressure and occasionally felt her heart racing, although it didn't really trouble her too much, and therefore she didn't really seek medical attention. However, she recalls having had a mini stroke 2 years ago when she was sitting on a bus in London, and she felt her right arm suddenly become weak and had a tingling sensation in part of her face, and that resolved after a few hours. So that sounds very much like a transient ischemic attack or a mini stroke. But she came to see me just for a general heart checkup, and when I saw her, her blood pressure was high, 150/90 millimeters of mercury. Normal blood pressure ideally should be below 130/80 millimeters of mercury. And her pulse rate was irregular and fast. So the first thing we do after examining the patients is to do an ECG. And clearly this showed that her rhythm was irregular, as you can see on this tracing. It was fast and irregular, and this is confirmatory of atrial fibrillation. So the usual test we would do in this sort of patient would be to check routine blood tests, check her kidney function, her thyroid function, because this can sometimes cause atrial fibrillation if she has thyroid problems. Check her hemoglobin to make sure there's no bleeding in case we need to start blood thinning medication. Very useful to do a 24-hour Holter monitor to check the heart rhythm over a longer period of time. And in her case, it was confirmed that she was in atrial fibrillation throughout the whole recording period. So she has something called persistent or chronic atrial fibrillation. And also an echocardiogram is very useful to document the size of the heart and whether there's any underlying heart problem or any problems with the heart valves. But her echo was relatively normal, other than having a large left atrium, which we often see in patients with atrial fibrillation. So this is quite a straightforward case of a patient who has cardiac risk factors, her blood pressure, her age, and she's had a previous mini stroke. She she clearly needs long-term blood thinning medication because she is at very high risk of developing a stroke in the future. And she also needs careful control of her blood pressure and regular checkup to make sure that she is on the right treatment and that her rate is under control with atrial fibrillation. But otherwise, now that she's been treated and on the right medication, she should have a good long-term outcome and she should do well. Second case is a different profile patient that we often see. He was a 33-year-old man who was a very avid sportsman. He cycled and ran regularly, cycled up to 60 kilometers in a weekend. And he, typical with this sort of person, wore a smartwatch that monitored his heart rhythm and rate. And he felt that he could see his heart rate increase excessively when he was exercising, more so than usual. And he also felt the heart rate remained fast even after he stopped exercising. So clearly this was not normal for him, and he knows what his heart rate normally does when he exercises. He's otherwise very fit and well with no past medical or cardiac history and no cardiac risk factors. Examination was completely unremarkable. Blood tests were normal. His ECG was normal when I first met him, and his echocardiogram and an exercise treadmill test was also normal. He has some isolated extra heartbeats during a treadmill test, but this is quite common and often doesn't relate to any underlying problem. This is his underlying ECG at rest, which is actually normal, although you might think that it looks a bit irregular because the gap between each heartbeat is slightly variable. But we often see this in young and fit people. We call it sinus arrhythmia, but it's still normal sinus rhythm. So in his case, it was very important to try to document his heart rhythm when he felt the symptoms. And the most efficient way to do this, because his symptoms were intermittent, was to give him a cardiac event recorder. So I loaned him out this Kardia device, which he carried it with him when he went cycling and running. And during one of the episodes, he managed to record his rhythm, as you can see here. And clearly it shows that the rhythm was very fast and irregular and different from his baseline rhythm. And this confirms something called atrial fibrillation or paroxysmal atrial fibrillation. But clearly this is a different profile of patient from the first lady that I showed you. This is a fit person who has paroxysmal atrial fibrillation. In other words, it comes and goes. So his condition is considered quite early onset because the rest of his tests were normal. And you can see from this medical slide that AF has a natural history that it progresses over time if it's not treated. It often starts as asymptomatic, then people have occasional episodes, and over time, if not treated, it becomes more and more frequent until it becomes permanent, which is the first lady that I showed you. And the earlier you pick up and treat AF, the better the long-term outcome will be. So in his case, he had early stage atrial fibrillation. We discussed the treatment options, which include regular medication or to do catheter ablation. And in his case, he was adamant that he did not want long-term medication because that would impair his performance and his ability to cycle and exercise. So he underwent a catheter ablation using a cryo balloon catheter, where we actually insert special freezing catheters into the pulmonary veins, and we can actually disrupt the electrical signals that trigger the AF. This takes about 3 hours to do. It involves an overnight stay in hospital and has a very good success rate for this sort of patient. So he had a good result, and he was off. He didn't need any medication, and he was back to his usual activity after about a month. Third case is a 17-year-old boy who used to play badminton for his school team, and he had experienced intermittent palpitations for about 2 years, especially when he was playing badminton, but he didn't feel that the symptoms were too bad until they started to get more and more frequent and more prolonged. He described very classically a sudden jump in his heartbeat and then very rapid heartbeats for several minutes before the heart suddenly returned to normal. So this is a nice description of a heart rhythm problem in a young fit man. His initial tests were also all normal, including his ECG, echocardiogram, and treadmill test. And so again, it was important to try to detect his heart rhythm problem when it next occurred. So I loaned him out a heart rhythm monitor and asked him to continue with his exercises, including playing badminton, and try to detect the heart rhythm when he next experienced the problem. So this shows the heart rhythm monitor during one of the episodes when he was playing badminton. His heart suddenly raced and shot up to 180 beats a minute. And you can see the heart rhythm is very fast and regular. And this is something called SVT, or supraventricular tachycardia. And the treatment for SVT for a young fit person is really to do catheter ablation, because the success rate for this procedure is over 98%. And for this sort of profile patient, you don't really want to put them on long-term medication for the rest of their life. This is a simple arrhythmia due to a fast circuit in the middle of the heart, as shown here. And the treatment involves putting the electrical catheter from the leg blood vessel to break or disrupt that electrical circuit in the middle of the heart with a very high success rate. So he had a good result and was back to playing badminton after about a month. The last case is a completely different profile of patients. I saw him about half a year ago. He was a 61-year-old man, enjoyed playing the guitar, and he performed in one of the bars in Singapore. But he was not very fit. He was under the care with his GP with minor coronary artery disease. He had high cholesterol and was on medication. And sometimes he felt he had skipped beats or extra heartbeats, especially after he was at a late night or when he had drunk a bit too much alcohol. But he wasn't too bothered about that. However, he came to see me because he had increase in stress at work. He felt the skip beats become a lot more frequent, and he started to feel really uncomfortable and dizzy when they occurred. He admitted that he had increased more and more his intake of alcohol with the increase in stress, and had also taken more caffeine, and his weight had increased because he had done less exercise. His initial ECG was normal, but again, he didn't have any symptoms when we did the ECG, so it was important to try to record his rhythm when he next had the symptoms. His echocardiogram showed a bit of heart muscle thickening because of the high blood pressure, but was otherwise normal. So in this case, this sort of patient, it would be more appropriate to perform a Holter monitor to try to document the rhythm, because he can't use a cardiac event recorder because the skip beats were too fast for him to record any heart rhythm problem. So I put him on a 3-day heart monitor and on a patch Holter monitor. And this clearly shows whenever he had the skip beats, he tapped the front of his chest wall, and you can see that this corresponded with these very abnormal signals on his heart. These are called ventricular ectopics, and he had very, very frequent ventricular ectopics during the 3-day period, about 3,000 to 4,000 extra heartbeats a day, which are clearly causing his symptoms. So despite the symptoms and the picture on the Holter monitor, they're not usually very dangerous as long as the rest of the heart looks normal, which his heart was. So I advised him to reduce his alcohol intake, to reduce his caffeine intake, reduce his weight, and try to get himself back on track to do more exercise. Because his symptoms were quite uncomfortable, I gave him a trial of heart rhythm medication for about 2 months. And 2 months later, I reviewed him again. He had managed to reduce his stress. He had lost a bit of weight. And when I repeated the Holter monitor, his skip beats were markedly reduced. He had about less than 50 a day compared to 3,000 or 4,000 before the medication. So as he had done a lot better, I managed to stop his medication. He continued to improve his lifestyle. And after 3 months later, he still remained well and was off medication. So this case is a patient who had quite severe symptoms, but the heart rhythm problem wasn't too serious, and it improved with lifestyle improvement and with a short course of medication. So last 2 slides then. What should you do to try to keep healthy and prevent or stop the chances of having a heart rhythm problem? The usual medical advice for heart disease is true in this case as well. Ideally, you should do regular exercise, keep your weight down, and check for sleep apnea. So if you have problems sleeping or snoring at night, or if you have episodes where you stop breathing, that should be assessed formally, because sleep apnea can increase the risk of heart rhythm problems. Try to reduce salt intake to reduce the chances of getting high blood pressure. We always say have a healthy, balanced diet. So that's important for heart rhythm problems as well as all aspects of cardiology. Try to eat a more Mediterranean diet, including more vegetable, fish, less red meats, more avocado and seafood. All of that is useful. Of course, reduce alcohol intake, which can increase the heart rate and also increase arrhythmias. And try to, if you can, easier to say than done during the situation in the current crisis, but try to avoid stress. Try to avoid situations that trigger stress or make the heart rate go faster. And of course, important to have regular medical checkup. Check your blood pressure, check your cholesterol level, check for diabetes, and also check your ECG. Because remember, as I mentioned, in older people, some people may have atrial fibrillation but not actually have a heart rhythm, not actually have any symptoms. So important to have regular checkup. particularly if you're above the age of 50. And the more dangerous signs to look out for that may signify an underlying heart rhythm problem rather than just benign palpitations are if you suddenly feel very, very dizzy with palpitations, or if you faint or lose consciousness. If your heart rhythm or palpitations suddenly increase, so if you're sitting down at rest and suddenly you feel your heart rate go fast, that could be more dangerous. If you have any history of heart disease, such as previous heart attack, or if you had a stroke, or if there's someone in your family who has died suddenly or unexpectedly, particularly below the age of 50, you should have further assessment if you have palpitations. If in doubt, my advice is to see a doctor to have appropriate evaluation. And if it turns out to be benign, then at least you can be reassured. But if anything is picked up, it can be managed and treated as appropriate. So I'd like to thank you for your time. Thank you for listening. And I'll pass back to Mike to decide on the questions. Thank you.
Great. Thank you very much for an excellent presentation, Reginald. I've got a few questions here from the attendants. I'd just like to say, if anyone's got any questions, just drop them in the Q&A box and we'll try and get through the ones that we've got time for. So the first question, Reg, is what do beta blockers do? How do they work?
Yeah, okay, thank you. So beta blockers are a commonly used group of drugs in cardiology. Essentially, they do a number of things to the cardiovascular system. They lower the heart rate, so they act on the sinus node, and they lower the electrical conduction in the heart. So they usually slow down the heart rate by about 10% in most people, but they also lower the blood pressure. They act on the blood vessels as well as the heart rate, and they can be used for high blood pressure as well. So often we use beta blockers either if the heart's too fast, we slow the heart rate, or if some heart rhythm problems can be useful for beta blockers, or if people have high blood pressure, we use beta blockers.
Okay, and can they be used in people with a pacemaker?
Yes, so if patients have pacemakers, then it means that they have a special battery and lead inside the heart that protects the heart from going too slow. So although beta blockers slow the heart rate shouldn't go below the preset level in a pacemaker rate because the pacemaker will protect them. So yes, so beta blockers can be used in patients with a pacemaker.
Okay, great. And a question here about supplementation. So 2 parts. Are there any supplements that you recommend that can reduce palpitations? And are there any supplements that can be helpful in reducing blood pressure as well?
Yeah, okay, thank you. It's a good question, and it's commonly asked as well. Essentially, supplements are generally, some supplements can be good for the heart and can lower the risk of palpitations. So some people take magnesium supplements, some people take vitamin D, some people take vitamin C as well. There's some evidence they can help reduce the symptoms of palpitations, but there's not a lot of good medical literature that shows that they definitely help, and that's why most doctors don't recommend supplements for palpitations. However, I'm not against supplements as long as they're taken in the recommended amount, and you see a doctor and you check things like your thyroid function or your magnesium levels before you take a lot of these extra supplements. The second part was?
Any supplements for blood pressure, high blood pressure?
Yeah, so I don't normally recommend supplements for high blood pressure per se. More important is to reduce your weight, to exercise regularly, and to reduce your blood pressure, reduce salt intake. But supplements generally might be useful just to keep your whole body healthy with the correct amount of, say, zinc, magnesium, vitamin D is important. There's a strong correlation between low vitamin D levels and cardiovascular disease. So I would say supplements are useful, but I wouldn't recommend supplements as a specific treatment for blood pressure because in themselves they're not sufficient.
Okay. Next question is about mitral valve prolapse. And is mitral valve prolapse associated with palpitations?
Yes, good question. So mitral valve prolapse, as some of you may be aware, is actually very common. Usually it's mild and doesn't require any specific treatments. However, there is a subset of patients with mitral valve prolapse that do get palpitations. Some people get atrial fibrillation with mitral valve prolapse, Other people get other heart rhythm problems because the mitral valve prolapse can actually progress and cause quite severe leakage of the mitral valve. So in some rarer cases, mitral valve prolapse can be more severe and cause palpitations. There's also there are one or two smaller studies that have shown an association between mitral valve prolapse and sudden death, although it's not very clear whether this is real and what the mechanism is. So I would say one has mitral valve prolapse, it's worth having it checked properly to decide whether or not it's anything significant.
So you'd recommend some test, someone had a mitral valve prolapse and palpitations, you'd recommend they got some tests done?
Yes, I do. Yeah, just to be sure it's nothing more serious.
Okay. Okay, if someone is starting to feel, if they're exercising, and then while they're exercising they feel faint, what could that be? Or is it worrying?
Yeah, so it partly depends on the profile of the patient, but generally any symptoms during exercise are potentially dangerous. The symptoms of palpitations or dizziness or fainting can be dangerous, and best to have it checked up. So the reasons for these symptoms could simply be that the person is not used to exercising and is exercising a bit too vigorously, or that they stop exercising too quickly and then they have a sudden drop in blood pressure. So it may just be simple faint because of a low blood pressure. But other times they may be dehydrated and not enough fluid, and then they feel faint because of that. But more sinister cardiac causes for that symptom could be that they actually have a real heart rhythm problem during exercise, such as ventricular tachycardia or atrial fibrillation or flutter, or they may have heart block. We've seen a number of patients that are apparently fit and well, but when they exercise and when they suddenly stop exercising, the heartbeat suddenly stops for 1 or 2 seconds instead of gradually reducing, and that can make people suddenly faint. And of course, the other very common problem, particularly in older patients with risk factors for heart disease, is coronary artery disease. If they're exercising, they feel very uncomfortable or unwell. It may be that they're having a blood vessel problem that needs urgent assessment. So if in doubt, better to check up, particularly if you have other cardiac risk factors.
Okay, great. I've got a question here about ablation. What's the difference between cryoablation and radiofrequency ablation?
Yeah. So essentially, from the patient point of view, they're both the same. The process is the same and the patient experience is the same. The ablation procedures are done from the same blood vessel. The main difference is really just the type of energy that we use. With radiofrequency, we heat up the tissue to destroy the heart tissue that's causing the arrhythmia. Cryoablation, you're freezing the tissue instead of heating the tissue. The more commonly used technique is radiofrequency ablation because it's been around longer, and it's got slightly better results for some types of ablations. But the benefit of cryoablation is that it's actually meant to be less painful. When you freeze the tissues, it's actually less painful compared to heating the tissue. And also, in some studies, it may be slightly safer because when you freeze the tissue, the permanent damage is caused after about 30 seconds. So if there's any problems before that, you can stop the freezing and then the process is reversed. Whereas if you heat the tissue, you can get permanent damage within a few seconds. So the doctor doing it needs to be very familiar and experienced with both techniques, but cryoablation may be slightly safer for some types of arrhythmias, whereas radiofrequency, more commonly used, possibly slightly better long-term success rate in some arrhythmias.
Okay, I've got time for one more question, then we'll probably have to wrap things up. So I've got a question about heart rate, and if someone's in their early 20s, can a heart rate of about 200 on their heart rate monitor during exercise be normal?
Well, I would say by and large that would be abnormal, unless that person is extremely unfit or overweight or really doesn't exercise much. I would say for someone in their 20s to have a heart rate of over 200 during exercise, it would be considered quite fast and abnormal. It doesn't necessarily mean that they have a heart rhythm problem, but I would say that it's worth having that checked out. Either just have a heart monitor when you exercise and just check the rhythm, or do a treadmill test, and then we can assess the rhythm during that time. But it may simply be, as I said, just a sign that that person not very fit, and they need to train the heart to try to reduce the heart rate gradually. But we don't want to miss the SVT. Like the young boy I showed you in the third case, he had a heart rate of 180, when he was playing badminton, and that itself was very abnormal. That was an SVT. So worth having it checked out.
Okay, great. So we'll wrap things up there. Thank you very much, Reg, for an excellent presentation. And thanks to everyone for joining us for this lunchtime chat.
Thank you.
Okay, thanks a lot. Just end things there. If you have any questions, you can drop us an email at inquiries@harleystreet.sg, and we'll try and get back to you.